Good morning and welcome from all around the world, broadcasting directly from the Mount Sinai Hospital in New York City. I'm Dr. Pedro Moreno. I will be your moderator today. Remember, we want to hear from you, so please send us all your questions and send us also through the website or through YouTube. And remember, we can view all these cases in our website, www.ccclivecases.org. We have a great case today, so let me pass you through the cath lab right now under Dr. Kinney and Dr. Sharma.
All right. Good morning to our structural webcast audience. This is, as you know, now has become monthly event, and we always try to show something different. And this will be a case of the TAV in TAV with the degeneration, which is we are getting more and more cases now because patients are living. The valve, I would say, is outliving the patient's lifetime, so they are coming back. And this will be a new disease process, which we all trying to understand. And some people do criticize us that we are showing a lot of TAV in TAV, but that is the real life. That's what happens. And we hopefully, with the due course of time, will understand how to optimize the results, just like stent took us 20 years to optimize by the intravascular imaging, and that decreased the total target vessel failure. So maybe for many things which we need to do at time zero so that the valve degeneration does not occur. So with that note, myself, Samin Sharma, on my right side, Dr. Kinney, left side, Dr. Sahil Khera. One is our system interventional director, the local director, and then, of course, Gilbert Tang, our surgical director. And then we have our structural fellow. We had two of them, actually three, and Dr. Panta here, and the rest of the team, Dr. Lerakas on echo, and with his team, and then we have Dr. Spencer, our anesthesiologist. With that note, we can start presentation of the case, and while we'll show what we do. In this particular case, these are our regular, and of course Pedro being a moderator. The goal today is to do a Redo-TAVR for Degenerated Sapien-3 Ultra transcatheter aortic valve, which was done about 6 years ago, and initially had a HALT, but then has a valve degeneration, and we are going to use Evolut Fx plus valve today. So this patient is an 81-year-old female and has an aortic stenosis, now has represented with symptoms about 6 months ago. The valve was done in May 18, so it's a 6 years plus. That time was a 23 millimeter Sapien. She did fine, except she had a trouble at the time zero. She had low platelets and she had a lot of bleeding in the kidney, and she was very much concerned today, despite the good platelet count, that we should not let the platelet drift down. So that's one of the, I would say, operational issue, that we need to give a platelet transfusion when the platelet count is about 85, 90 on her. So she, when presented about 6 months ago, we did, because of shortness of breath, I did the echo, and it was read as a HALT. We did both TE echo as well as the CT. And I'll ask my team here that my personal experience has been that if purely HALT, once you put on anticoagulation, this patient we started Eliquis, she could not tolerate the warfarin, and we did the few echoes since then, since March, and nothing has improved. Symptoms continued, and so question is, maybe actually Stem can talk about it also, because he called me on that day when the echo was done, and he said it looks like a HALT. And then the patient was not on any anticoagulation at that time, because patient was always in sinus rhythm, and we started her on Eliquis. Start high dose, but platelet count went down to 30. We had to go down to 2.5 milligram, and she had a lot of bleeding issue. So Stem, back then, if you recall in March, you're very confident that this patient's degeneration of the valve was more of a HALT compared to the true valve degeneration back then.
Yes. Good morning from New York. Dr. Sharma, thank you. And on my right is Hafizur, our structural sonographer. As you can see here, this is gastric images of the left ventricle, which looks normal, actually hypertrophied, a small cavity. Here is the mitral valve and the tricuspid valve, normal RV function, no much mitral regurgitation, no much tricuspid regurgitation. And this is a zoom image of the transcatheter aortic valve today. And as Dr. Sharma said in the beginning, in March, this patient had what we say by CT, a HALT, which is basically hypotenuation on the base of the leaflets in the LVOT area, and you can still see that one of the leaflets, which is corresponds to the left cusp, doesn't move. And as you can see, in the base of the leaflet is still some minimal thrombus there, hypotenuation that we see with CT. The other two leaflets that you will see, they are thickened and and move some, but not completely. This is the short axis, and you can see the two leaflets, the no-coronary corresponding leaflet and the right leaflet. They are thickened and they move not completely, but the top leaflet you cannot see very well because of the artifact from the frame of the valve, but that leaflet is not moving, and if you can see it more, you can see that doesn't move almost at all.
Okay.
Again,
so,
this is explained. You can see again the leaflet, one of the leaflets doesn't move. Dr. Sama, you would like to say something?
yeah, no, my only question was the definition of the HALT. I know you can see it on your TE echo or other, transthoracic sometime, but on the CT, CT also appeared that it was a HALT at that time. Gilbert, you want to comment on that?
Yeah, that's right. It was consistent with the echo images. So that suggests that, this is, a problem that we've seen about 10 to 20%, right? Based on the partner trial, based on the Evolut trial, low risk trial, that, we still don't understand the full extent of it, right? Because some of them at 30 days happen and then they disappear 1 year or vice versa. But clearly, I think Stan and I have talked about this with you and Dr. Keenan Sahil as well. The HALT is a precursor. If it does not go away, it's a precursor for potential degeneration.
And that exactly
you have
happened.
a CT scan at that time.
Yeah, we have CT scan. Yeah, CT scan also showed that. So Stan, then now and this is what different from then now that the one leaflet is totally became immobile, right?
Yes. So basically now the one leaflet is still.
Show the echo, please.
Echo, please. No angiogram yet.
The one leaflet, as you can see, which corresponds to the left cusp, doesn't move. You can see it clearly.
Yeah.
The other leaflets are thickened. They move, but not completely, as you can see from the gradients. So I think the HALT with the therapy, the coagulation therapy, went away on the two leaflets. On the other one, remained partially. But also the leaflets, I think, degenerated. As we know now that the HALT can progress even if you treat it to degeneration of the bioprosthetic valves, and I think that's what happens in this patient, because as you will see more images, she doesn't only have, this is a 3D image, you can see the leaflets thickened, and one of the leaflets that corresponds to the left doesn't move.
Okay.
And also, as you can see here, degeneration, at least moderate central aortic regurgitation because of the degeneration. So it's stenotic and insufficiency. No PVL is central aortic regurgitation. This is the short axis view. Again, you can see the moderate aortic regurgitation. This is a deep gastric image. You can appreciate the leaflets thickened and don't move very well. Moderate by measurement, as you will see, valvular aortic regurgitation, no PVL. The pressure half time is 423, which is consistent with moderate valvular aortic insufficiency. Again, another image of the deep gastric images of the bioprosthesis. This is the pulse wave, and acceleration time 124, which is we use to separate true aortic stenosis. In this case, is not the issue compared to patient prosthesis mismatch. If it's less than 100, it's consistent with patient prosthesis mismatch. On this patient, of course, is degeneration more than 100. Mean gradient of 50, peak velocity 4.3. Actually, the velocities by transthoracic echo was more than 5.
Yeah.
And aortic valve area 0.6. So severely degenerated aortic bioprosthesis. We started with HALT and moved to complete degeneration.
Yeah, so this is a great point. So there's a paper from the Vancouver group that just talked about the mechanism of degeneration of these transcath that was a bit different actually from native valve and also surgical valve. That you don't need to see calcium to actually see degeneration, and they've done the explanted specimen and actually look at microscopy and show that even non-calcific degeneration actually is a problem for these valves, which is basically what you're seeing here, because you see that the leaflets are not stuck like a surgical valve or native valve, but despite that, look at the gradient, and that's something that we're still trying to learn.
So very beautiful, I mean, ideal case showing that now I have about 4 or 5 cases where the HALT, we put anticoagulation and that gradient disappeared. Few of them actually. Right now, another patient I saw just yesterday, whom we put originally, people ask if the HALT, how long you continue. Those patients we continue only for 1 year. And then we stopped it and they remain asymptomatic. And the gradient significant improvement. So with that note, let's go back to our slide presentation. So this was a little atypical case, and just emphasizing on the point that one of the mechanism of the valve degeneration, no, go to the first slide, yeah, good. Degeneration is the HALT to start, and let's look at the gradient now, very high. 110, velocity was 5.3. In this particular case, patient good medication, non-obstructive CAD about 50-60% are circumflex, which remain the same way now. So this is basically, we have gone through the finding. Now anything from the valve point of view, it was a nicely deployed valve.
Yeah, so I mean, we don't have the pre-TAVR CT on this patient because it's 2018. Ideally, we want to get that to see how much sizing, oversizing or undersizing or true sizing you are. But we have this now, the post-CT, you can see it's pretty well close to expanded, slightly underexpanded, across the entire, Sapien-3 frame. You measure the inflow, the mid, and the outflow. Next slide. And you can see that this sinotubular junction and sinuses are not that generous. You can see that here, and you'll see that in aortogram soon. Next slide. So what we look at, and you can use Vinny Bapat's Redo-TAVR app, but we basically look at, are the coronaries clear for the second valve? And if so, which valve would you choose? And I think there's an important considerations here. So in this case, the patient was lucky enough to have high takeoff for the coronaries, such that the Sapien valve, the top of the valve, where the leaflets will get pinned, is just at the level. We saw that nicely in the aortogram and angiogram soon to the audience. But this is kind of first step to look at what roughly the distance is going to be, whether you have coronary obstruction of one coronary, both coronary, or no coronaries at all. In this case, there's no issue with coronary obstruction. But coronary access will be an issue afterwards if you use a tall valve, so we have to discuss the strategy of what valve you're going to use as a second valve and where you're going to put the second valve in. Next slide.
Now, let's go back to the angiogram now. Okay. So I think this will be the right time. We did the angiogram today, and patient has a mild disease. That's okay. This is the plane. Yeah, let's go back to our fluoro. Yeah, look at that. So just coming at the top.
Yeah, so literally right at the top, and we can fast forward to show you all the... So this is what we call the frame alignment LAO cranial view. That's to show the left main takeoff, because obviously you don't want to jail the left main, but you can see if you put a tall second valve, be careful about coronary access down the road. Now this patient is 80 plus and only moderate circ disease, but if someone has really significant disease, you have to think about that. And then we also did the right. So you can see the right corner is clearly well above. So that is less of a concern. But still, coronary access may be challenging if you use a tall valve versus a short valve. But because we know that the short valve already failed after 5 years, that's why we are not using that in this case. The aortogram also, again, you want to see what the sinotubular junction and the aorta looks like. If it's very big, then you don't have to worry about it as much. But this is kind of just the right fit, I guess. It barely made it.
Now let's go back to the point. Why you're saying a short valve versus tall valve? That's tall valve failed, short valve failed?
I think both valves are absolutely fine here. I mean,
no, question is that should you use here again same balloon expandable valve, or you put now the self-expanding, which will be the tall valve, and that's where you have to worry about the coronary access. So just to make a disclaimer, our plan was if the circ lesion has progressed, we would have wanted to put a stent now and then do the valve in valve. So question then comes is the patient's preference. Patients say, oh my God, this valve lasted only 5-6 years or so. So please use a different valve. So that is one of the reasons in this particular case. If somebody says, why would you not using another Sapien valve? There's no contraindication. Actually, a lot of people will use another Sapien valve.
Yeah. So Raj Makar's JAMA paper does show that if you put a second valve as a Sapien, that the gradient is higher afterwards. That's the difference.
So the point is patient prosthesis mismatch. It's not really that you're having same HALT is going to happen in the same short valve. I think both valves are fine here. So it just depends what you want to accept. Do you want to accept patient prosthesis mismatch, or are you worried about you want great gradients? And I don't think reaccess will be a problem. We can show after putting an Evolut how the reaccess is.
Okay.
No, going back to the point, is it mechanical factor? I don't think the HALT is mechanical factor in this patient. She may still got it with low platelets.
Yeah, there's a lot of multifactorial. We don't know the answer.
Biological.
But one theoretical benefit is you have tall leaflets in a supraannular platform. They're less prone to sort of, in general, degeneration because of the area of the leaflets itself. So theoretically, it makes sense.
Right.
Okay, so let's go back to our slide presentation again, so we could complete a combination of all. Slide again, yeah. Good. So this is the femoral axis.
So Sahil should make a comment about access with these Redo-TAVR cases. It's very important for the audience to know. So
yeah, Redo-TAVRs are in general just more fibrous groins, so just meticulous access. Otherwise, straightforward, I'm not really concerned.
No, but you are thinking about putting IVL in this particular case.
I think it looked like, there's a lot of blooming artifact in the iliacs. I took an angiogram, looked great, no IVL. Sheath went in without issues.
I see. Okay. Now, what about the sentinel?
We did a sentinel. It's a HALT case, HALT degeneration. You can see little thrombosis on the leaflets. It's a chronic thrombus, but I just feel anytime you do a valve-in-valve or a Redo-TAV, it's a high risk of stroke, and we should protect the cerebral tree.
Okay. So coronary obstruction, the high chance of stroke. What about pacemaker?
Well, pacemaker rates valve-in-valve has not been that high, so I'm not really concerned.
So biggest question is the coronary access. I mean, really the crux of the problem for the valve-in-valve or Redo-TAVR all is their coronary access, and that many times determine what to do. Okay, with that note, we are ready now. And Anu, tell us this angiogram we already have shown. Aortogram, we are ready to cross the valve now. And sometimes it's a little difficult to cross. And then whole question is that do you go with the pigtail with the J wire rather than your usual, which we go with the straight wire tip?
Yeah, pigtail J wire should do it. You can see one leaflet is pretty mobile. So yeah,
good.
See, it's very easy.
Yeah. So it depends on the mechanism. That's why echo is so important. And we did a live case recently, right?
Yeah.
With a failed valve that it was very stenotic. It was very tough to cross. And so, this is something that you actually need to talk to your imager to make sure you understand the mechanism of degeneration.
Yeah, you're through. You're through.
Yes, thank you.
So first we are going to pre-dilate.
Yes. So that's one important point that we all discuss as a heart team. Some people just put the second valve in there, and the data show that if you put a second valve, it's very hard to post-dilate two valves because of stent. And I'm sure it's a similar thing in the coronary world as well. So what we plan to do is to put a true balloon, 23 true balloon, so it's true size. We don't know the native anatomy, but it doesn't look like there's a lot of calcium. So in terms of risk of rupture, should be low. And then what will happen is that after that, then we'll put the Evolut, but then we'll also post-dilate the two valve because remember, one is a self-expanding valve, one is a balloon expandable valve. There can be gaps between the two valves and not well expanded, so you need to optimize the expansion because you don't want HALT again on the second valve, and you don't want the second valve to fail early because the patient came because the first valve failed about 6 years. So I think it's very important to optimize what we call optimize the landing zone before you put the second valve, and then optimize the two valves afterwards. And if you've seen all our live cases, we always consistently done that because we really believe in making sure the valve we put in is in optimal condition as possible.
Yep.
Gilbert, question to you.
Yeah.
Right now, by doing pre-dilation, would we embolize it?
No, in terms of the valve is very secure.
No,
right?
not the valve, the thrombus.
Yeah, absolutely, that could be a possibility. That's why we have to put a
So why don't we just
device.
go ahead without?
Huh?
No, you want adequate expansion.
Yeah, you want because the second valve will be even smaller if you don't expand the first valve. We've seen it before. And
post the redo is once you have a valve in place, if you don't pre-dilate it, the post becomes harder because now you're contracting two frames.
Tee up, please.
So we selected the 23 millimeter. That was the valve size back then, and the same one we'll use after also.
Yeah, it's the same balloon. Yeah,
same balloon. Okay.
Because also Medtronic, you don't want to damage the Tee up, please.
Yeah, we don't need the T right now. Yeah. Good.
180.
180.
Just a comment about the anticoagulation here. What are we using?
Heparin and ACT is 350.
Yeah,
350.
So
Okay.
yeah, and then patient was on Eliquis before only one agent.
Do you want me to do
and
it
then
again?
we
Off. You want me to do it again?
Apixaban, and we only question is patient cannot tolerate any aspirin or clopidogrel because develop significant thrombocytopenia even on aspirin.
Yeah.
Yeah, actually
Look,
that.
Sine, beautiful.
Yeah. So question was whether the halt was responsible, occurred because patient was on no antiplatelet therapy.
Wait.
So after 3 months of the valve, every anticoagulation had to antiplatelet therapy was stopped because patient developed severe thrombocytopenia, both on aspirin as well as on Plavix, clopidogrel. So and then even she developed on 5 milligram of apixaban, went down to 65.
Val, please. I think
so she has continued somehow. Any of this anticoagulation, antiplatelet therapy has a negative factor on thrombocytopenia on this particular patient. So biggest concern for the patient was not where we are doing the valve in valve. She always was just wanted to worry about her platelet count, and we reassured her that don't worry, your platelet count is good, and we'll give you some transfusion anyway.
Yeah, the incidence of severe thrombocytopenia defined at more than 46% of baseline is have a 57% mortality at 2 years for TAVR. So it's a very serious condition.
Yeah, absolutely.
So with the self-expanding in the balloon expander, we typically like to bring the valve to the outer curve. So push the wire a little bit, I think, just exactly. And exactly. So we want to optimize the beginning because it can dive deep because it's different size, right? So, okay, 150.
Start opening.
No. Push the wire a little bit because it's going deep.
Push now. Okay, good.
Good. Very nice.
Nice.
Okay, 100, please. Okay, so you can you can see that the valve, the Evolut frame
is good.
Is below here. You can see that here. We take the parallax out the Evolut. Okay, you can see below, and it's going to be locked in right there. Good. Okay, so it's all below the frame. Okay, so that's very important.
I want to go one more view.
No, looks very good.
Looks very good. Yeah.
Yeah.
It looks very good.
How much are we pacing at?
Okay.
100.
Good.
Good. This is good.
It's actually good.
Yeah.
Okay.
Yep.
Send to the wire, please.
Yeah.
Wait 1
Okay.
second.
It's good.
Okay. Good.
Yeah, below.
Yeah. Okay.
It's not below.
Yeah. Is it? Okay. So 150.
Send to the wire. More. Center more. Good.
So the valve frame is locking, so you just slowly release the valve, and it's going to set itself. No rush here. You want to be able to slowly release because remember there's tension in the system. Good.
Okay.
See?
Little more.
Yep. Good. Okay. All right. The valve is released. Okay. 100, please.
100.
Okay. Watch the tab. No, the tab is still engaged. You see that there?
See another view.
You see that? Okay.
Come this. Come Mario. Good.
Okay. Good. Free. So now you're free. You have to make sure you confirm.
So now push the wire slightly.
Mm-hmm.
So frame interaction can be a big issue in these cases.
Good.
You have to be careful.
So now get to the
and
outer
get me
curve.
the 23 balloon.
Yeah. Good. So always check one and one view. So land exactly the free dots.
The system.
Below there. Back up, please, now.
Let's walk it out.
Yeah.
And get me the postal balloon.
Yeah.
Go ahead. Good. Beautiful depth. Exactly where you want it.
Mm-hmm. Good. So we don't want to aim too high because when you post dilate, it can foreshorten.
Yep.
So there have been reports of pop out.
Yeah.
Because of the valve was implanted high and you post dilate and with the extra bead. So that's why it's very important. If you need to, like yesterday, we did 2 valve and 2 freestyle route, which you can't see anything. So another trick is that because we have our anesthesia team here, we can actually ask them to stop ventilation to minimize the respiratory motion when we deploy. Now in this case, was not necessary, but yesterday it was absolutely necessary because the mechanism of pure AR, so it's much less predictable. So that's why we do these cases under general anesthesia and TEE guidance. It's not because of convenience, because we have TEE. We want to make sure we got it done right because the patient already had a first valve.
180.
And Sine.
So you can see the Evolut frame expanded very nicely inside the Sapien frame.
Pacing, keep pacing.
Okay.
Good.
Off.
Let's do some
Pigtail.
hemo. Let's do some. So another important point is that that's what we call frame to frame leak. So you see the first Sapien frame has the leaflets, right? But then the Evolut frame might not be fully opposed. You might actually leak across between the two valves.
Yeah.
So that's why we post-dilate as well. And I think that will now serve the patient well in terms of at least optimizing the second frame as to avoid underexpansion. So Stam can maybe show us some echo images once you put the pigtail in.
Yeah, so
show the echo now, please.
Well-positioned valve. No PVL. There is some central AI from the pigtail catheter. Yeah. Okay. Let's go to the stomach. 2D.
So Dr. Sharma, what do you think? I think it's important to look at hemodynamics after these cases, right?
Absolutely, to optimize, and because clearly the gradient of 20 has been associated with the higher valve degeneration and subsequent need for another valve after within 2 years. So clearly you want to bring it down to less than 20, preferably in single digit. You'll have some gradient. So as long as it's in single digits, the invasive echo gradient may still be 12, 15, but as long as hemodynamic. So now what can we do? We are 23 millimeter true balloon. We may go to 24 if necessary, if there is still a gradient, which always you risk a little bit that your valve, can you destroy the valve leaflet? That's what, it's routinely being done. But we are doing a hemodynamics here.
So show the hemodynamic screen, please.
Zero everything.
0 first.
8 min, 11 peak by echo.
Okay, and transgastric looks good, Stan, with the PVL in terms of let's show the audience.
If the gradient 11 by echo, our hemodynamic will be about 6 to 8.
Yeah, please show the echo screen, please, for the audience.
Echo first.
Yes, fantastic, great. Okay. So they'll zero the hemodynamics, and then Stan will show us about the transgastric. Stan, can you comment, where do you look for PVL, what views on TE for the audience?
PVL, the best views is the gastric views. As you can see here, take the color off, please. Please off,
So we have a pigtail across,
explain
gradient of 2.
Yeah, there's no PVL. That's
explain,
Once we take it off, it'll be nothing.
So you put explain on the deep gastric. As you can see here, that's the valve, put color. You can see no PVL. You can move it around to see it's a little bit centrally minimal.
And look, you saw the hemodynamics, no gradient now.
Yeah, okay.
I want to do an LV.
So the best view for PVL is gastric images.
Great. Thank you, Stan. And also, no central AR anymore, right? That's the other thing. So this is a mixed degeneration, I think, Dr. Sharma. What do you think?
That's exactly correct. So we can get TE up. So we do the aortogram now. Make sure catheter goes inside pigtail. And then we are going to show the engagement of the left coronary. The right we are not less worried about. Left could be.
T probe up, please.
Because with the moderate disease, we're trying to go with the.
Stam TE up, please.
And where is that opening of the FX plus is in this case on the left side?
We'll find out.
If we can see it.
Fantastic. So you can see that's what I was talking about.
All right.
Enough clearance.
Go to JL4. You want 3.5 now?
Good.
You need a smaller one, right? 4 will be too big.
Yeah.
Get a JL 3.5.
We want to show
what do you want to see on the coronaries?
Left engagement of the left coronary to show how FX plus is revolutionizing the coronary engagement, which have been an issue with the self-expanding valve, particularly with the Evolut and core valve. So this particular case, and she may need CAD intervention, because you saw that circ at the bifurcation was about 50-60%, 50-55. It used to be around that. Now what happened to blood pressure?
No, pressure
is zero.
Yeah.
So you can see here, this is the view to look at the big cells. You can see the two big cells on the right side of the screen. By putting one of the dots on the inner curve, you can see it. So
the LAO projection, no? Go to the LAO.
No, LAO now we can see, but if you want to, because the cells, the large cells, there's no radial markers around the big cells. So and overlays with the small cells.
Wow.
So you need to be able to
really engage will be a remarkable. Wow.
This is to show Gilbert that it's doable. He was a little concerned about redo.
Yeah. I mean, what I was concerned about is that if you implant the valve high, because the inner skirt will be preventing you from doing that, and also commissure misalignment. Thank goodness we actually have good commissure alignment here, which I think makes a difference.
No, it's just in the sinus. It's not engaged.
Rotate a little bit and let's take a picture.
Yeah, you can rotate as much as
there.
And let's do the cine.
Yeah, it's not bad.
No. You're not engaged. It's non-selective.
Yeah, as long. Oh, you came out now.
Get a J-wire.
You should have
It's a
taken
short
that
catheter.
picture.
Should have used a photo.
No, that is a JL.
So
You need a
3.5.
3.5.
Yeah.
This is 3.5.
The next.
Just that's okay. You are just there. Take it. We are not doing the PCI right now. We just wanted to see that we could get in a good position. No. You need JL4 or what?
Yeah, maybe JL4. Yeah, that's okay.
Good. Okay. Good.
That's probably okay now.
Yeah. Yeah. Let's see. We are not planning to do any PCI yet.
Thursday.
Well, I think the key here is that, so here is right, you can use either valve as long as you don't implant the second valve too high.
Do me
and you
AP
understand the
caudal, take
design
one
of the
picture, we are
second
done. And we go to our more discussion point now.
You can
Just
start
to
your
say,
discussion.
engagement will be much easier. That's what the point is, that's what being made. Yeah, see right there. Okay. So we know that you have to manipulate the catheter, that's fine. So we saw that.
Yeah.
No impingement on the coronary. That is the biggest problem with the valve and valve. With the fluoro, take the wire out with the catheter out without any trouble.
No, we are out.
It's out.
No, the catheter is out?
Yes.
The pigtail, everything is out. Yeah.
No, this JL.
It's out. It's out.
Okay. All right.
And it says, assuming you need to go with a guide, which one would you use?
No, I think this will be a 3.5 with a guide engagement or VL30. VL30 will be very good, right there. Okay, so let's go to our presentation. Nicely, all the steps have been done while they are trying to close the groin. Using what? 2 pre-closes, 1 pre-close, or what?
Two pre-close, yeah.
Two pre-closes. Okay. So with that note, let's come to the latest one. I always try to present the what is latest, and here is recent publications in the field of TAVR. One is a series of notion trials. Now we have 1, 2, and 3. Then recent meta-analysis of surgical valve versus TAVR valve, long-term data, and the impact of the cerebral embolic protection devices on stroke, the data from the TVT registry, and so. So clearly, we know first one, notion trial, 10-year outcome, done in Denmark and Sweden, low-risk patient, randomized STS less than 3, all using core valve, randomized to surgery versus core valve. We have the data up to initially 1 year, 5 year, 8 year, now we have the 10-year data, and this is the nutshell. In the middle, as you can see, curves are absolutely overlapping in 10 years. What is the other advantage that we saw with the TAVR? That you have slightly less valve degeneration. Although non-significant, but it's slightly less valve degeneration. But more importantly, the valve gradient on the right side. The valve area and valve gradient slightly better with the core valve versus other. Individual endpoints are shown on the top. So what it basically mean? That if somebody makes the claim the surgical valve lasts longer than the TAVR valve, answer that is wrong. We have a randomized trial, 10-year data that both are identical. That's one point. Therefore, clearly, now the second. The second point was Notion 2 trial. The Notion 2 trial, again, same Denmark and Sweden. And question was, if you take a patient, young patient, 75 years of age or below, and low STS risk, include everybody. Yeah. Include the bicuspid anatomy also, unless it's a very hostile, and then randomized to the TAVR versus surgery. And in this study, all types of valves were randomized. In the Notion 1, everybody was core valve. And here, core valve was about 35-40%. Then the Sapien valve was about 25-28%, and every valve, Evolut, Portico, Accurate Neo, everything was there. So just to say, all FDA approved, they're actually my valve also in this, that any approved valve was used, and then question was, where are we in this low risk patient? 75 STS actually was 1.1. And if you can see, basically that both were identical in terms of major point, which is death and stroke. Once you do hospitalization, then you may do a little better. But key is the major points were the same, but I'm a little concerned that even at 1 year, that we have our event rate about 3% higher in the TAVI group compared to the surgical group. Although p-value was not significant, and as you can see here, but key is that within the 1 year data, we have 3% adversity. What do you want to say on that? 1 year, we have 3% on the low risk patient, 27% are the bicuspid, and I'll come back to that.
Yeah, I mean, it's interesting that it was not seen in the partner or Evolut low risk in the United States, but you can see in this particular figure, Dr. Sharma, the panel D, I think that's where the difference came from, that the TAVI for some reason had a higher stroke than surgery. So not disabling stroke because the panel F shows similar, but so that is something of concern, I think, in terms of why. I think we still need to understand that.
And key is, and therefore they looked into it, all the partner trials or even the Evolut low risk trial, the patients who were less than 70 were in single digits. So those patients, although we cannot say that they were randomized, although supposed to be, but in real life, until this trial, we did not have much data because there was single-digit enrollment of less than 70 years of age in those other trials. So coming back to the point, so as much as we are happy about it, as you can see that clearly the stroke rate 5.4 versus 1.6, not the disabling, but the stroke rate and the bleeding, of course, was higher. Of course, AFib is less, and of course, pacemaker is higher. So whatever we knew overall and lower length of stay. So overall, this, I can tell you, as good as or happy I am for the TAVR, it just made us to little think, pause, and look into the young person, and many of the mean age will be about 66 and so, and person with a low risk, knowing that those have not been evaluated before. If you're having a 3% difference, I predicted in Excel trial, at 1 year, we had a mortality difference of 1.2. And then in 3 years, that difference became 3.2, which is comparing cabbage versus PCI in the left main disease. I said, this is going to become important. And at 5 years, the difference became 5%. So key is that just to say that telltale sign of very early is concerning. So not to say, there is a lot of enthusiasm about the TAVR valve, but we had to think about what exactly the data from the notion in a young person with a low STS risk came. And of course, the valve performance, KCC score and everything much faster with a TAVI group compared to surgical group, and the valve area and the mean gradient was kind of okay, but definitely a little better for the TAVR valve versus the surgical valve. Now, this is the key. And what is the key? That there is a big difference in the tri-leaflet valve versus bi-leaflet or bicuspid valve, which was about 27% of cases. Look at the event rate. Is almost 3 times of death and MI, disabling stroke from 2% to 6.1%. This bicuspid, and these are the bicuspids which were not the hostile anatomy. Which were, if a hostile anatomy was excluded, because those patients we knew they could not do the TAVR. So excluding that, bicuspid, to me, whatever the difference, I think the 3% difference is all related to this one quarter of patient has such a 3-time event rate in the bicuspid group. And that was a big, big issue. Because primary endpoint, if you take the rehospitalization and all, it was the 3.9% in the surgery, and it was 14.3 in the bicuspid. So bicuspid, definitely we have to pause what we do, whether we need to do a dedicated, another randomized trial with more focus on the big valve area, and how we need to modify the valve modification techniques, and so it need to be seen. And individual, as I said, there was more paravalvular regurgitation, and so forth, overall event. So basically, the conclusion of the Notion 2 trial, that among low risk patient, age less than 75, STS was 1.1, so real low risk. Patient with severe symptomatic AS, the rate of composite death, stroke or rehospitalization at 1 year was similar between TAVI and surgery. Transcatheter aortic valve implantation outcome in young bicuspid AS patient warrant caution and should be further investigated. I mean, caution, to me, it's a big caution here. So what do we tell our patients now with that? Anu? After the Notion 2 trial, particularly the bicuspid. Now, as you know, there was a bicuspid registry in all the trials, but it was only registry and selected patients were done. So we can't even say any data we have for the bicuspid in our low risk Evolut or with the Sapien-3 valve.
No, it's a hard thing. They see young patients, that is what we do here in Sinai. Means when they are young patients, low risk, they do see the surgeon. And we say our part, the surgeon says their part, independent. They are seeing them not in the same room, in 2 separate offices, on the same day, different consultation. Then the patient makes the decision.
Sahil, your point?
Yeah, no, I think Dr. Kini mentioned everything. It's end of the day, it's a low risk patient, less than 75 with bicuspid, and bicuspid comes in different flavors and shapes and sizes. So if it's feasible for both, yes, both options should be presented to the patient. But clearly, if TAVR is even remotely risky, I think patients should go for surgery.
And the editorial actually on this one exactly highlighted the heart team decision.
Yeah.
And then we can make our recommendation to the patient, but it's ultimately, the heart team decide whatever you recommend to the patient, and then patient make the final decision. But they need to know that this is where we are on this valve. So this basically put together in nice one graphical abstract with the bicuspid versus tricuspid. The bicuspid is the bad news. Maybe we need to have a dedicated bicuspid trial, and there it has to be that what kind of valve and all we are going to use. Okay, so there is a little bit on the slide issue. Okay, then the Notion 3 trial. So Notion 1, Notion 2. So Notion 3, there was the prevailing concept. PCI with a TAVR is harmful because few studies have shown. So this actually took into this group again. He said, what if we do a PCI and a follow-up up to 5 years? The average follow-up was median was 2.2, but we had minimum 2-year follow-up of PCI or conservative therapy patients with a TAVR. And here also all types of TAVR were used, but PCI was done pre-TAVR in majority of the cases. PCI first, then successful, then patient was randomized to TAVR with FFR guided PCI or go to conservative management. FFR guided if lesion was from 60 to 80%, but it was 90%, then you can do without the FFR guidance. And patients were followed, primary endpoint being all-cause mortality, MI, and urgent revascularization. And what did we find? And this is here on an average of 2.2 years, you can say that revascularization with the PCI compared to conservative treatment was beneficial by decreasing the MACE, 3 endpoints of the death, MI, and urgent revascularization. You can see here, and even the stroke, everything was lower except the bleeding was higher. And there was actually surprisingly the acute kidney injury was not different. So just to say that PCI, now we have one randomized trial, large group of patients that's showing the PCI before the TAVR is better. So now these are the individual endpoints have been shown, and basically is the urgent and revascularization. They did show also that if you have a 90% lesion, that probably made the big difference here. Anytime you have 90%, very high event of subsequent revascularization in this group of patients, as you can see here. See your diameter stenosis less than 90 and more than 90 is the one PCI was better. So therefore, conclusion was among patients with coronary artery disease where undergoing TAVI, PCI associated with a low risk of composite death from any cause, myocardial infarction or urgent revascularization and median follow-up 2 years, then conservative treatment. So basically this was, and this is also the valves were big, the majority of any types of valve was used in this particular case, like kind of half and half. The final answer in this field is the ongoing trial of the largest number of patients, 4,000. With a complete TAVR, we are part of it. We have done about handful of cases. Every month we are doing 1 or 2 patients. And it basically is, patients have successful Sapien deployment and then not a left main, and then randomizing the patient to PCI or conservative treatment, but after successful TAVR. So this is where the trial ongoing, but it will take at least another 2 years to complete it. They are not even 1/4 done yet. So then question comes, the long-term outcomes of the transcatheter versus surgical valve, meta-analysis of the trials, and what we have the data point of view, that death or disabling stroke in terms of the left side and the right side. And if you can see there is no difference in terms of surgical risk, whether low, intermediate, and high. The curves at the unity in the center. And then if you go by the TAVR valve, if you can see, there is a little bit of favoring the surgical valve if you compare against the balloon expandable. But if you go to the self-expanding, you are a little bit on the left side. Again, no difference, but just to give you a little signal that when compared within that group of the balloon expandable versus self-expanding, we have a little better data of the self-expanding compared to surgical valve. But just to say that anywhere follow from 4 to 10 years, no difference in the death and MI or disabling stroke in 2 groups. And now one of the thing also was the valve thrombosis. Now, valve thrombosis has been reported in the partner trial, as you know. But we have the Evolut and the low risk and the TAV is almost unheard of. So clearly that advantage of the self-expanding valve is beyond that they have a slightly lower event rate, as I showed, and also lower thrombosis except high pacemaker. So clearly the high pacemaker, so that's the disadvantage, but otherwise both self-expanding, balloon expandable did okay, but slight trend toward better of the self-expanding valve. Actually, we just finished this week the final 3 patients of the TAV 10-year. So 10-year is all done. And the patients still looked okay. I mean, but again, only problem is we are seeing only 30-40% of cases because 60% are dead for whatever reason. And that's what you saw it even in the low risk 10-year of the Notion 2 trial at 10-year, only 26% patients are alive. But that's the part of it, the disease process and by age itself. So TAV good. So now, so therefore the other question is, in UK and Europe, they made a 75 cutoff because they apparently people work till 75 years of age, and after they retire. In America, probably people retire maybe sometimes a little early or get some kind of a benefit. So there is a 75 years cutoff, lower versus higher. Lower go for surgery. In America, less than 65 surgery, more than 80 TAVR, in between heart team discussion. So this makes good program. Now, is it being followed? And look at this one. This we have another data on the patients with the TAVR versus surgery. Look at that one. Less than 65, 65, 80, more than 80. I think we are doing very good in more than 80. 65, 80, based on the risk group, they are getting majority. I would say 80% getting the TAVR. But look at the left side, less than 65. There is a big indication creep of the patients getting the TAVR, almost half of them in this current day and age, getting the TAVR compared to surgery. Gilbert, what do you comment on that?
I mean, I think the thing is that remember the FDA approved the valve for the safety, right? Not based on age, there's no discrimination. So, once the device is approved, patient and the heart team can decide to use it. So I think that, obviously everyone wants to avoid surgery, but the question is that to your point, based on the other trial data, is that the right thing to do? And that's why I think Dr. Keeney mentioned that you need to have a heart team approach of an equipoise, and then you present all the options to the patients, short-term benefit versus long-term benefits or caveats. I think that needs to be articulated. And now, more importantly, with the CT scan, we also tell people, if you get valve A at this time, can you get another valve in the future? I think that's also very important now, because if not, and there's no technology, let's say down the road to help with this, they may need surgery, and they need to be aware of that.
So one question I'll probably ask SS and AK, that 55-year-old patient comes to you in office and is a very great candidate for TAVR and SAVR, and Redo-TAVR is possible. And the patient says, listen, I have my family commitments or taking care of a parent or, kids getting married. I cannot take 2 weeks off for surgery and recover. Would you consider TAVR in that patient? So there are a lot of these situations, and I want to know what you think, what both of you think.
Anu, you want to answer?
Yes, sir.
Yeah, so I mean, the key is that somebody who is 50, 55, you think about patient will need 3 procedures in their lifetime unless patient has a COPD, CVA or bad CAD. So the question is, some people say, you know what, I'll do the TAVR now, then I'll get a surgery, so I'll still have then chance to get 1 or 2 TAVR after. Now, only problem is the surgeons is still in a very early stages of the experience on the TAVR explant. If the TAVR explant surgery becomes they become expert in it and bring it down to mortality of not 1%, maybe 2%, compared to it is now the 6, 7 or 10, 12 by various group you go, at least 3 to 4 times of the native with the first time the surgical mortality. So that will is preventing us to give this approach. So question comes, you do the TAVR now, but your next surgery will be not surgically, will be TAVR explant.
Yeah.
And then another valve. So now the risk is a little higher. So that's where, yes, in some situation you want to do it because the patient knows. And I actually have a patient about 3 years ago, the patient dentist, 62-year-old, has a bicuspid but favorable bicuspid. We brought the patient, our surgeon, Dr. Al-Hamamsi, went to the patient, discussed it. Patient said at 62, I cannot take time off. Exactly you say. If 72, I'll take a time off. And I cannot have my practice will disintegrate otherwise. And we did the valve. So I'm just saying the cases are different, but only question in this scenario is expertise in the TAVR explant. And I'm sure many centers, the mortality is going down. And how are we in terms of our mortality
I
at
think
Sinai?
the learning curve is still there. I think we can do it safely, but with a caveat, depends on how long the valve's been in there. The longer the valve it is, the more incorporated with the tissue, it's hard to explant. But going back to your point, not that they might not be, we might not want to offer TAVR on them, but if we do, we have to do a good job. I think that is the key success of our program, and we need to make sure, like this case, right? A lot of people would put a second valve in and not even pre-dilate, post-dilate, and get out, and then you have degeneration early, and then now you're in the deep doo-doo, right? Then now you really need to have an explant. So I think the message is that we heart team decision. If the patient chooses TAVR, just a hill set, young active patient needs to be back on their feet very quickly. We go ahead, but make sure you do a good job. Make sure there's no PVL. Make sure you look at the echo properly to make sure when you leave the room that you've done the best job you can for the anatomy. I think that is the key message, and I think Dr. Sharma would say that that's what we've been doing in our program.
Yeah, Sahil, any further comment on that?
No, I think maybe Dr. Kinney, you have something to say.
And Stam, you want to make a comment
No,
about?
my thing was, I think of a young age, 55. I think you have to discuss same. Since your TAVR explant has to become very low risk surgery. Right now, it's still, though they're saying certain centers are becoming better and better with it, that you have to present to the patient. Once if the patient understands that, and sometimes they're adamant that they just do not want surgery at this age, will go for a next age. But also depends on the CAD. If they have extensive CAD, there's no other option.
Right.
I think they should, even at 55, with extensive CAD, go for SAVR plus bypass, versus if it is just valve. That's where I think we will be.
Stam, you look at all these echoes. I mean, what's your opinion about young patient getting TAVRs?
I mean, we have to present to the patients the data, and as you say, we have to do a great job. And today, I tell people that when we started this with the partner trial, we were measuring LVOT on 2D, and now we have 4D CT.
Yep.
So the technology is tremendous. We have to use the technology, take advantage of the technology, CT, 3D TE, echo, and do the best for the patient. Even if we do it for young patients, with the technology we have today, we can have excellent results. And as you say, you have to make sure no PVL, good expansion of the valve. You do the best we can, so the valve can remain functional for a long time.
Long time. And the other point is that if a patient has decided they're not going to go for surgery, if we don't do it, somebody else will do it. And we actually had lost few patients in the past. Now we are very proactive, and we have a heart team discussion that basically, this patient, if we don't do it, is going to get done. That defeat the purpose of the program. So therefore, as long as everybody is more patient to understand what is getting into, and it's not a contraindication. And contraindication is the hostile valve anatomy. If that is hostile, then it's a different story. But otherwise, it's a reasonable to do this. So let's just come back to the last one. Is the important impact of the cerebral embolic protection device in disabling stroke after TAVR. Data from that ACC TVT registry. As you can see, that of course we want to decrease overall. What we have found that only 35% or 36% of the centers are using cerebral protection in America. That's one. It used to be 40%, gone down to 6% down after the protected TAVR results. Second, patients are in teens only. As of now, it's still only the cerebral protection device. No trials are different. We are part of another Protembis trial, but the trial is very small because the TriGuard trial failed. There are 2 other trials ongoing at present, but that's maybe 1%. But majority that in America at this point, only high teens are being used, teen numbers are being used for the Sentinel. Sinai is around 50%, but some biggest contraindication is right radial issue or the tortuosity of the great vessel. Those are the 2. But that's just to say, now what they found basically is same of the protected TAVR result. That embolic protection decrease your disabling stroke, but not your other stroke. Understood. So that basically the answer is what we understood. The same thing they followed in this trial. So coming back to the point, let me conclude now, taking first our the notion trial family. That one, the notion 1, 10-year equal, slight, maybe a lower bioprosthetic valve degeneration in the TAVR, slightly trend lower. Then at notion 2, 1 year TAVR versus SAVR equal for death severe but events higher in the bicuspid aortic valve group. And then in the notion 3, 2 to 5 year with a median of 2.2 year, lower death MI revascularization after PCI versus conservative group. As I said, final answer will be our 4,000 patient complete TAVR trial. Recent meta-analysis of the TAVR versus surgery showed the various STS risk group that death or disabling stroke, but higher pacemaker with self-expanding TAVR. Relative reduction in death or stroke risk and valve thrombosis was higher with a self-expanding versus balloon expandable TAVR valve compared to surgery. So clearly, some signal is there for the self-expanding valve, although there is no randomized trial data yet. Then, despite the guideline recommendation of TAVR over 60 or 65 years of age, there has been dramatic increase in the TAVR procedure in patients aged less than 65. This indication creep very concerning, as many of these patients likely have bicuspid aortic valve where TAVR efficacy is still debatable based on the notion 2 trial. So that's the biggest concern in the young patients doing the TAVR. Lastly, recent meta-analysis from TVT registry regarding the impact of cerebral embolic protection devices showed their benefit in reducing disabling stroke, but not all stroke or minor stroke. Hence, a case can be made of use of embolic protection device in all TAVR cases if possible. Even because disabling stroke is a big issue, because we do it's about decreased by 1%. Same thing in the trial, decreased by 1.6%. We change our treatment by decreasing 1% mortality, aspirin versus streptokinase versus the direct PCI, primary PCI. So 1% decrease in mortality is a very big effect, because all those patients with a disabling stroke end up in dying with higher mortality. So let's come back to the 3 questions. The patient, the notion 2 trial, true except means what is the wrong? Primary endpoints were similar between TAVR and SAVR. Stroke rates was higher in the TAVI versus SAVR, and severe patient prosthetic mismatch was lower in the TAVI versus SAVR. TAVI results are similar in tricuspid versus bicuspid valve groups. We know that. Wrong answer. Bicuspid was very bad. Then the notion 3 study involving PCI versus no PCI showed the following, except lower MACE rates in the PCI versus no PCI, higher stroke rate in the PCI versus no PCI, higher bleeding in PCI group, lower urgent revascularization in the PCI group. Yes, clearly there was no difference in the stroke rate. Third, the following statement is false regarding the long-term effect of TAVR versus SAVR. Death rates are similar between TAVR and SAVR. Pacemaker implantation is higher in TAVR versus SAVR. Valve thrombosis is higher with self-expanding valve versus balloon expanding TAVR. And disabling stroke rates are similar between TAVR and SAVR. Clearly the C is the wrong answer. Valve thrombosis is lower in the self-expanding valve versus the balloon expandable. With that note, I complete my presentation, Pedro.
Yeah, thank you. Thank you so much for the HART team. Excellent case, beautiful demonstration of perfect technique. And we will always want to hear from you. We didn't have any questions today, but next time we will have it. Remember, our case will be available at ccclifecases.org. And most importantly, our structural life cases are now every month on the second Tuesday of the month at 9 a.m. Next one will be November the 12th. Thank you very much.